welcome to the recorded PowerPoint of pregnancy examination. This is going to tie into what we talked about last week and be more actually about what we're going to talk about during our case studies during class on Thursday. I wanted to put this slide in because we had not really talked about the presumptive, probable, and positive signs of pregnancy. They are different. Presumptive signs are those things that are more subjective. So your patient might have nausea and vomiting. They might have weight gain, but those could be from other things. So they are presumptive, but they are not completely positive signs of pregnancy. There are also probable signs of pregnancy. These are more likely. So the patient looks like they have a fundal height. Yeah, more objective, but not necessarily positive. The patient might have a positive pregnancy test, but that could be because of other things too, like maybe even a false positive. Then there are positive, absolutely positive signs of pregnancy. These are things like obvious fetal movement, fetal heart tones found that are easily distinguishable from the mother's heart tones. And then ultrasound, of course, we look in there and we see the baby waving back at us. Pretty positive that there's a pregnancy with that. Then there's the testing, the urine and the serum, beta HCG, which we had talked about before. So what are the goals of prenatal care? Well, of course, we want to have the birth of a healthy baby for the patient, and we want to minimize risk of the mother. How are we going to do this? Well, UpToDate is pretty specific about some things that we need to be doing with our general prenatal care. One is to estimate gestational age correctly. This is why we're seeing more and more use of ultrasound in the first trimester to try to really get to when this baby should be due. It has to do with everything else we do in pregnancy. When do we do the testing? What should the measurements of the fundus be? When are we going to start having signs of labor? Things like that. We also want to identify risk factors. We look at several things, including the patient's current pregnancy history, past pregnancy history, personal medical history, family medical history, all those sorts of things to try to figure out what we should be expecting or anticipating as healthcare providers. We want to provide ongoing evaluation of the mom and baby during prenatal visits, and we want to anticipate problems and try to intervene to decrease the risk of any morbidity occurring. And of course, we want to educate and communicate patients, and how better to do that than seeing them on a regular basis, particularly with a huge life change like pregnancy. So the initial pregnancy visit is focused on history, physical exam, and education. For education, we use a lot of anticipatory guidance. Personally, I feel like knowing about cognitive load theory, that we tend to cognitively overload our patients at the first prenatal visit. The good thing is that most of them are excited about being pregnant, and they have already gone out and learned a lot of this information themselves, so a lot of what we tell them is just reinforcement. We also want to do a complete history, like I had mentioned in the previous slide: obstetric history, medical history, family history, looking for any problems that might occur during the pregnancy, and to establish a risk category for the patient. We also want to make sure that prenatal lab has been ordered, or we can send for it if it's been ordered someplace else. And we'll talk about exactly what to order here in a few minutes. Prenatal vitamins. We want to make sure that this patient is on prenatal vitamins. You would not believe how many people come in to see you and are already 10 or 12 weeks pregnant and have not been on prenatal vitamins. And quite frankly, by then, it's almost too late because of the big importance of neural tube defect prevention with folic acid. But that is one thing that you want to make sure to check off of your mental list. And then a complete physical. And during this complete physical, as well as everything else that you're going to be looking at, you want to establish a baseline blood pressure, look at height and weight, and then pay special attention to the uterine size during your examination. A couple of things that I've cut and pasted from UpToDate for you. Some of the things that they have reviewed, and you can look those over in your own UpToDate, but basically initial prenatal social demographic assessments that you want to go over with the patient. And then past obstetrical history. Really looking at that obstetrical history of the patient can give you some really good ideas of what might go right or wrong with this current pregnancy. And then, of course, current pregnancy history, any medications that they've taken. Have they used alcohol? Do they use cigarettes? Have they had recreational drug use? Those sorts of things. And then I want you to review on your own from your pharmacology class that FDA administration, or that FDA pregnancy category list for medications that the patients are on or have been on during their first trimester of pregnancy. Natural changes of pregnancy, we can talk about this a little bit more during your case studies, but I want you to review, even from your old obstetric book, which I'm sure you have on yourself, right? Just what are some of the typical things that we would expect, some of the natural changes of pregnancy. When we go beyond these things is when we have to worry as clinicians. And we'll really address this when we talk about your case studies. So if you don't know these right off the top of your head, for example, EENT, many women will have problems with copious amounts of nasal drainage. They'll actually have more pitulism, that excessive salivation, those sorts of things. So you want to be aware of those and know when to tell your patient, oh, that's a typical sign of pregnancy, or, ooh, that sounds kind of odd, we need to check it out. So here are the list of laboratory assessments. You can read through those. I won't read them for you. But when you get down to the bottom, others done by clinic protocol. Some clinics do a wet prep on every patient to check for pre-existing infections. We do that at our clinic. We find that it's very important to do that. Treat infections early, and especially if they're STI, for example, if they have some sort of trichomonas, then we want to make sure to check them very closely for other STIs. However, chlamydia and gonorrhea is pretty much done by everybody now. The PPD or quantiferon, we tend to do quantiferon in our clinic because we have a very ethnic, diverse population, and a lot of people have already had the HCV vaccination in their country of origin. And then, of course, additional anemia strains. If you think that there might be any pre-existing problems with sickle cell anemia, or you want to order a hemoglobin electrophoresis. Some people will have escaped having that done in their adolescent age if they get pregnant early enough. If high risk, may also add a TSH, maybe some overt diabetes testing with an A1C or a fasting blood sugar, and then, if you think it's appropriate, a lead screen to the patient. How do we estimate EDD? Remember when we talked about the first slide, one of the most important things about prenatal care is to correctly estimate the EDD. Well, we can use Nagel's rule if people really know their last menstrual period. Patients are so cute. Sometimes they'll come in and even say, I know exactly when and the hour that I conceived, and I know exactly all of this. But most patients are really not that cognizant of when they might have received, or they might have conceived, or they have irregular periods, unsure of their last menstrual period. So ultrasound is very effective for this if done within the first trimester. And we'll talk about that a little bit more here in a minute. Uterine size. Remember when we talked about examination, you want to pay special attention to the size of the uterus because that can give us some ideas of gestational age. Normal uterus is about 3 by 4 by 7. If you can get that 3D picture kind of in your head as normal, then when we talk about an 8 weeks gestation pregnancy, within that normal uterus, it's going to get about 2 times the size of normal, or about the size of an orange. 10 weeks is about 3 times the size of normal. 12 weeks, 4 times the size of normal. Kind of a size of a grapefruit, a typical grapefruit, not a monstrous one. Now this is also when the uterus starts to get right at the top of the symphysis pubis but has not come out of the pelvic cavity yet. As the uterus grows, 13, 14, 15 weeks, it'll come out and be able to be palpable at the fundal height, or the top of the fundus, within the abdominal wall. 2 really common markers that we use in pregnancy. 20 weeks is usually when the fundal height is at the umbilicus, and 16 weeks is when the fundal height is somewhere between the umbilicus and the symphysis pubis, so it's about halfway in between. And those will be important for you to know. Routine care. Typically, we like everybody to have prenatal care initiated by 10 weeks, but sometimes that doesn't happen. And then, of course, there are some people that call and want in at 4 weeks gestation, but we try to make them wait just a little bit longer. Depends on the clinic, once again, when they want people to present. Every 4 weeks, we will see this patient until they're about 28 to 32 weeks. Again, it kind of depends on the protocol of the clinic. After 30 weeks, the typical is about every 2 weeks until they get to be 35 or 36 weeks. At 36 weeks, every week until 40 weeks. And then after their term, we'll discuss more of that management a little bit later. At each visit, we should have the MA do a urine dipstick, a weight, a blood pressure before you see the patient. Some clinics may also have the patient or the MA take care of the subjective information, but I tend to feel like that's something that I want to know myself, and I want to make sure that those questions have been asked and that patients have the opportunity to get their questions answered. So during that, with looking at that urine dipstick, we want to make sure there's no glucose, protein, or leukocytes. We'll talk about that in the case studies. We want to see how their weight is going with the stage of pregnancy, and are they gaining effectively, too much or too little. What is the blood pressure? Is it about the same as the baseline blood pressure? And then we want to check fetal heart tones. They are available somewhere between 10 and 12 weeks with the handheld Doppler. Up to date says 12 weeks. That's pretty cautious because most of the time I can find them around 10 weeks in a patient whose body habitus allows me to do that. So subjective information, you want to ask the patient if they have any cramping or contractions. Have they had any swelling? Make sure you use their language. Do they feel the baby moving? Had they had any bleeding or unusual discharge that's bothering them? Signs of infection that might be there. Do they have any problems? Are they having any questions that aren't getting answered? And then we educate them for the time in pregnancy, and not only verbally educate them, but also send them home with some handouts to review. Fundal heights are important at each visit. We want to measure from the symphysis pubis to the fundus or the top of the uterus. In general, 1 centimeter on that measuring tape will be 1 week of gestation. Remember, at 12 weeks, just above or at the symphysis pubis, and we're not going to be able to use our measuring tape much there. But 16 weeks, we get to have an idea that it's somewhere between the symphysis pubis and the umbilicus, and 20 weeks at the umbilicus. Remember, when you're measuring, at 36 to 40 weeks, you might get less of or maybe a leveling off of the fundal height because of the way that the baby and the uterus itself tends to go down or move more progressively toward getting ready for delivery, and the baby drops. So that is expected. So when do we worry? Well, in general, within 2 centimeters of variation is typical between practitioners, and that's acceptable. But if you get over 2 weeks, it's different. You definitely want to be looking and see what's going on with ultrasound. Here's a good example. If you have a patient who should be about 18 weeks and you're measuring 21 weeks or even 20 weeks, that's kind of a stretch, at the umbilicus, and you're thinking, I wonder why is this baby growing more quickly? Do we have too much fluid? That sort of thing. So you would want to go ahead and order an ultrasound. Yeah, this is subjective, but it's a very inexpensive screening tool that has been working for years, so we continue to use it. Here's a picture of where you might see those fundal heights. See right here at the 20 week is about the umbilicus, and then 1 centimeter per week as we go up. 36 weeks is usually higher sometimes than 40 because the baby is dropping down into the pelvis and getting ready to be delivered. Important testing times. So when we see these patients, they're not always going to fall dead on one of these 15 to 18 weeks, so we use those as guidelines. We want to offer all patients AFB, triple screen, or quad screen. I use all 3 of those terms because your preceptors may use different terms. In general, the quad screen is done at this stage in the game because it's the one that gives you the most information. And we offer that between 15 and 18 weeks. Now remember, it can be done as late as 22 weeks, but it gets much less accurate. So we'll talk about that in class. Glucose screening should be done between 24 and 28 weeks on all women. This gets to be a little bit of a controversy because some patients who have no family history of diabetes are gaining weight effectively. There's no problem. Should we really be drawing them? So we'll talk about that debate a little bit as well. Most providers also draw an H&H to check for any anemia at this time, and if the patient's Rh negative, we'll draw an antibody screen. If the antibody screen is negative, we give them an antenatal precautionary dose of RhoGAM at that time. And then the other thing that's really important is the group B strep screening, somewhere between 35 to 37 weeks. This is a vaginal and rectal swab, but if a patient comes back with a urinalysis or a culture that has grown group B strep, they are considered group B strep positive without having to do an additional culture. So when do we do cervical checks? Well, not often. In fact, we try to not do them as much as possible just because it can introduce infection. Some clinics do not check regularly at that last 36 to 40, the weekly visits, but some do. Some clinicians want to know if the patient has been progressing, if the cervix has been changing at all and getting ready for labor. So it just kind of depends on the provider. We also do a cervical check if there have been any contractions and concern about preterm labor. If a patient has had problems such as incontinent cervix, we can do it, but you know what? Ultrasound is kind of replacing that. And then bleeding. We don't want to do a vaginal exam with a bleeding OB patient because we might cause more bleeding. We tend to get those patients inpatient and try to use our other diagnostic tools. Leopold's maneuvers. I want you to review this. You can review it online or review it in your OB text if you have it at home. When will we use it? How accurate is it? It really depends on the provider, and generally we use it to try to see is the baby vertex or head down, and of course we know that's more conducive to delivery. Ultrasounds, we've kind of gone over this before, but when is ultrasound done? Well, it kind of depends on the provider. Some practices do some different things. In general, the best time to assess the due date, or EDC, EDD, is the first trimester. Mid-pregnancy, Almost all clinics now are ordering a mid-pregnancy, what they call fetal well-being screen and growth to check for any problems that might have occurred. So around 20 weeks, and you'll hear people talk about the 20-week ultrasound. Has she had her 20-week ultrasound? Because it is a pretty general thing that we do nowadays. And then third trimester, when do we use it? Well, definitely not for EDC at that time, unless they're presenting for first prenatal care. It's just not very accurate. So we use that to assess fetal size. For example, if we have a gestational diabetic mom, does the baby have enough fluid? Is the baby growing too big? Is this the estimated fetal size thought to be too big to even get the baby through the vaginal area, that sort of thing. We want to check for position. We want to see, is this baby breech, is this baby transverse, vertex, all those sorts of terms that you're probably remembering now from your OB days, unless you are a current OB labor delivery nurse. I thought this was a nice little chart from Up to Date, so I added it to really think about assessment of gestational age and really how accurate is it? Well, this says it all, really. The mean sac diameter, if you can get an ultrasound somewhere between 4 and 6 weeks, we're going to be pretty darn accurate on that fetal gestation. Crown to rump length is used somewhere between 7 and 10. You're going to have a window of like 3 days of accuracy, which is really, really good. But you'll notice that as crown to rump length gets up to be 15 weeks or 15 weeks of gestational age, you're looking more over a week here or there, give or take. And then, of course, biparietal diameter or head circumference and femur length are two things that ultrasonographers use to help us try to figure out gestational age. But if you can see over 30 weeks, we are going to be way off on some of that, just because babies grow at different rates. Babies might be real small, babies might be real big. It just sort of depends, and a lot of that depends on the parents and their size. So I hope that this has been helpful for you to help give you some ideas of what we're going to be talking about with our case studies on Thursday. I'm excited to meet back up with you and hope you have a good couple of days until we meet again for class. Thanks.